Hello, my name is Ryan Tomlin. I'm the clinical pharmacist at Mercy Health St. Mary's. I'm going to be talking to you all today a little bit about some basics in regards to HIV and the treatment of HIV in preparation for the live training session here in a couple weeks. Just as an FYI, there will be a couple questions at the end of this webinar and the following webinar, just as a quick review, just a quick quiz to make sure that you all got this information. The objectives of this presentation are to cover some brief basics in regards to epidemiology, the prevalence and the incidence of HIV both across the country as well as here in Michigan. We'll also talk about what HIV is, what some common lab values that we look for when we're treating patients with HIV. We'll talk a little bit about the HIV life cycle, and we'll also go over the medication classes and where they work in the HIV life cycle. Finally, we'll talk about some basics in regards to building an HIV regimen to treat a patient. This is a slide from the World Health Organization that shows the overall number of people across the world currently living with HIV. This slide shows the total number of people across the world as being about 35 million people. And that number has actually increased by about 1 million over the course of the last 3 years. So the overall increase in the number of people with HIV is kind of due to two different factors. One is that people are still continuing to be infected with HIV, but the second thing is that those that are currently living with HIV are actually living longer due to new treatment and more effective medications that we have. That is reflected on this current slide, which shows the total number of deaths from HIV and AIDS in 2013. You can see on this slide the total number of deaths is about 1.5 million across the entire world. That's a very large number, but the good news is that that number has actually decreased by about 300,000 in the last 3 years, again due to the fact that we have medications that are more tolerable and that work a lot better at suppressing the virus. This next slide shows the number of HIV cases in the US. This slide is from the CDC, and the most updated information that we have from the CDC surveillance is from 2010, so it's a little dated. But this slide shows the major groups of people that are infected with HIV, most predominantly being the MSM population. And then you can see the breakdown of the total number of people by each different category that the CDC uses as classification. If we look now at some specific statistics in regards to the prevalence, deaths, and diagnosis of patients with HIV in Michigan, you can see that the overall prevalence of HIV has continued to trend upward, very similar to like it has in the US and across the world. Again, the major factor leading to this increase in prevalence is the fact that people that have HIV, due to the medications, are living longer. You can see even while the prevalence continues to go up, the rates of new diagnosis is actually trending downward. This is again because when we have people on medications and the virus is suppressed, the chances of transmitting the virus goes down. And so we have fewer diagnoses due to effective therapy that we have on the market. In addition, as you can see, the overall deaths in the state of Michigan has continued to trend downward as well. When we look at the age group for new HIV cases in Michigan, this was an interesting stat that the HIV/AIDS surveillance for the state of Michigan pointed out in their latest report, in that while we have newer cases of HIV overall trending downward, in one specific age group, the 20 to 24, that has actually been increasing slightly over the past couple years. And finally, this is just a slide showing the overall prevalence of HIV across the state. So you can see the darker areas where we have more people living with HIV are really centralized around areas with larger populations in the state as a whole. So now that we've talked just briefly about the overall epidemiology of HIV, we'll look at what HIV itself actually is. So the definition of HIV can actually be found right in the name. So human immunodeficiency virus is what HIV stands for. Human meaning that the virus is only found and transmitted between humans. Immunodeficiency meaning that the way the virus works is by damaging human CD4 cells, which are responsible for keeping bacteria, viruses, and other infections away from the person. When HIV damages these CD4 cells, it weakens the immune system. And then finally, virus. Virus is a type of infective organism that reproduces by taking over a specific host cell. And again, in this case, it's the CD4 cell. The virus will get into the CD4 cell, make more copies of itself, and then in the process kill the CD4 cell, weakening the person's immune system, then making them more susceptible to other types of infections. When we treat someone with HIV, there are 3 very common lab values that we'll get on almost every patient when they are initially diagnosed. The first one is the viral load. So this is a very simple lab that just simply states how much HIV virus is currently in the blood. The overall goal with the viral load is to get that number to be as low as possible, because the lower the viral load, the less damage that the virus is causing to the body. The second number that we'll look at is the CD4 count. Again, since this is the type of cell that the HIV virus infects and then eventually damages and kills, this is the type of cell that we want to actually be as high as possible. The CD4 count is a good indicator for how strong the person's immune system is, and when the CD4 count gets very low, then the patient's at risk for other types of infections and can potentially end up in the hospital. The final lab that we'll look at least at baseline in a lot of patients, is a genotype. What the genotype is basically a test that looks at if HIV has found any way to avoid certain medications or developed any type of resistance against our medications. When we get a genotype, it will show mutations that the HIV virus has developed, and as a result, which medications may not be as efficacious against treating that HIV virus anymore. We use tests like this to help guide treatment and determine which medications may work best for certain patients. This is a slide that shows the overall time course for a person living with HIV if they're not on any medications. The yellow dotted line there is the CD4 count for a person. So you can see during the initial infection that CD4 count will drop quite a bit. Then, over the course of several years, anywhere from 2 years all the way up to a decade, the CD4 count will actually slowly decrease. Once the CD4 count gets below about 200, then that's when the person's at risk for several opportunistic infections, and then that's also when the person is at risk for being in the hospital. The pink dotted line shows the viral load. Again, during the first couple weeks of the infection, the viral load will be very high during the acute infection. After a couple weeks, the immune system does a pretty good job at getting a hold of the viral load and then causing it to get suppressed again. Over time, though, without medications, the virus will continue to replicate and will slowly trend upwards. In particular, when the CD4 count gets below 200 is when the immune system is too weak to keep the virus suppressed, and you get a large spike in the viral load. Eventually, when the immune system gets completely depleted and the viral loads get very high, the person's immune system is no longer able to prevent even very simple infections from very common bacteria and viruses in the environment, and then that person eventually will end up dying. Now again, this is a time course for someone who's not on medications, and when we start someone on treatment, we hope to reverse this by decreasing the viral load and increasing the CD4 count. Here we have on this slide the overall goals of therapy. So again, as I mentioned, we want to increase the CD4 count. When the person's CD4 count is above 200, then that's usually when they're in the clear and they have a strong enough immune system to prevent other types of infections from other bacteria and viruses in the environment. Preferably, we would like to get it above about 500 because that's when the CD4 count is back in the normal range. But really, when they're above 200 is when we're happy enough that we don't need to start any sort of additional antibiotics to prevent other types of infection. Our goal with the viral load is that we want that to be completely non-detectable. When we start someone on medications, we hope that we can actually get the virus suppressed such that our labs can't even detect the virus in the blood anymore. At St. Mary's, our lab can detect the viral load down to 40 copies in a milliliter of blood. So anything less than 40 copies we consider undetectable. In addition to these labs, we also want to improve the quality of life for the patient. We want to start therapy that's going to be tolerable and that will not have too many side effects. And we want to reduce secondary HIV-related diseases. The virus can damage lots of different parts of the body, anywhere from the heart to the kidneys to the eyes. And we want to start medications so that we can suppress the virus and reduce these secondary diseases that can potentially be caused when the HIV virus is growing unchecked. Now that we've talked a little bit about the HIV and the common lab values that we use when we're treating someone with HIV, I want to spend the rest of the time talking about the HIV life cycle as well as the medications that we have and where they work in this HIV life cycle to prevent HIV replication. To begin with, we have the HIV as a free virus roaming around in the blood. When the HIV comes in contact with a CD4 cell, it will bind to the CD4 receptor on the surface of that CD4 cell. Once it has bound to that receptor, it must also bind to one of two co-receptors, either CCR5 or CXCR4. Once the virus has been bound to both the CD4 receptor as well as one of the two co-receptors, it can then fuse with the surface of the CD4 cell and empty all its contents into the CD4 cell. HIV is a unique virus, and it is known as a retrovirus because it converts RNA into DNA. DNA is basically the building blocks of life that are found in every cell in the human body. Whenever a cell replicates, it copies its DNA to make another cell. Well, HIV is RNA, which is a single strand of building blocks, whereas DNA is basically a double strand of building blocks. HIV uses an enzyme called reverse transcriptase to convert its single strand of RNA into a double strand of DNA. Once it has made this DNA, its building blocks more closely resemble human building blocks. Now that the HIV has successfully disguised its building blocks to look very closely like the genetic building blocks of a human, it uses an enzyme called integrase to insert its viral DNA right into the middle of the human DNA. After that, the CD4 cell goes about making a copy of itself just as it would, only instead of copying its DNA, it in turn copies the HIV DNA. In essence, the HIV disguises itself and uses the CD4's own replication to make more copies of itself. Once the CD4 cell has made more copies of the viral DNA, this DNA then gets turned into proteins, and those proteins then form a new HIV virus. Once those proteins are then packaged back into the HIV virus, HIV uses an enzyme called protease to break up those proteins and to form a fully mature HIV cell, or HIV virus. Once the HIV virus is then formed, it buds off from the surface of the cell and goes and infects another cell. Now, if we go back and look at the beginning of this life cycle, we can point out where all the different medications we have on the market work at different steps in preventing this HIV replication. The first is CCR5 inhibitors. We have one medication currently on the market that binds to the CCR5 receptor and prevents HIV from binding to that co-receptor. When the HIV can't bind to that co-receptor, then it can't fuse with the surface of the cell and empty its contents. We also have a medication known as a fusion inhibitor, which works on that fusion process. This fusion inhibitor essentially acts as a spring on the surface of the CD4 cell that prevents the HIV virus from coiling down and releasing its contents into the surface of the cell. Instead, the virus is pushed back up off the surface. That way it can't empty its contents. Finally, we have two different classes of medication known as nucleoside reverse transcriptase inhibitors as well as non-nucleoside reverse transcriptase inhibitors. Both these classes of medications work on that reverse transcriptase enzyme that converts the viral RNA into DNA. If the virus is unable to disguise its RNA as DNA, then it can't use the CD4 cell to replicate itself. And we'll talk a little bit more in depth about how those particular medications work a little later. Next, we have medication classes that work on the integrase enzyme. These medications prevent the HIV integrase enzyme from taking the HIV DNA and inserting it into the human DNA. Again, if this process is halted, then the HIV is unable to use the CD4's own replication to make copies of itself. Finally, we have protease inhibitors. Again, protease is the enzyme that's responsible for taking the protein chains packaged within the HIV virus that eventually break apart and make a mature virus capable of infecting another cell. These protease inhibitors basically prevent that protein chain from being broken apart, and thus the HIV is forced to remain immature, incapable of infecting another cell. This slide illustrates all the medications that we currently have on the market for the treatment of HIV, broken down by each one of their categories. We're going to look in depth at each one of these types of medication classes and review a little bit more about how they work at preventing HIV from replicating. The first class of medications that I want to talk about is the nucleoside reverse transcriptase inhibitors. This is the most common class of medication that we use when treating HIV. Again, as I mentioned in the overview, when HIV copies itself, it uses RNA as a blueprint to make DNA. DNA is made up of multiple small building blocks or genetic material that HIV uses to make a copy of itself. These NRTIs work in that they look very similar to these building blocks that make up the DNA, but they're shaped just slightly differently. Because these NRTIs have a slightly different shape, the reverse transcriptase enzyme includes them in building the DNA, but then when it tries to add additional pieces onto the end of the DNA, it can't because of the differences in the shape of the medication. And I have a picture that illustrates this on the next slide. Here you can see the reverse transcriptase enzyme as the kind of Pac-Man shape there in the middle of the picture. This reverse transcriptase enzyme moves along the RNA, which is the blue circles along the bottom. Every time it comes up to a blue circle, it finds a green circle to add to the top of it. This converts the RNA into DNA. These nucleoside reverse transcriptase inhibitors look very much like the building blocks of the DNA, only again they have a slightly different shape. The reverse transcriptase enzyme takes the medication and includes it into the DNA because it looks very similar to the pieces of the DNA. However, because it has a slightly different shape, when it then tries to add additional DNA pieces after the reverse transcriptase inhibitor has already been added, it's not able to because of that difference in shape. Because of this, the process of turning the RNA into the DNA is halted because the reverse transcriptase can no longer add DNA pieces because the nucleoside analog has been incorporated into the chain. Here we have a list of all the currently available NRTIs on the market. Rotravir, or AZT, was the first HIV medication that was discovered, and it is still used in a handful of patients today. In addition to Rotravir, we also have Epivir, Xiagen, Viriad, Emtreva, Zaret, and Videx. NRTIs are commonly used in pairs when we're treating HIV. Most HIV regimens have 2 NRTIs plus at least one other medication. Because we commonly use the NRTIs in pairs, there are also several pills that co-formulate 2 of these medications into one pill. Combivir is a combination of Retrovir and Epivir. Epsicom is a combination of Epivir and Xiagen. Truvada is Viriad and Emtreva. And then we also have Trizavir, which actually combines 3 of these medications all into one tablet. The next class of medications that I want to talk about are the non-nucleoside reverse transcriptase inhibitors. This class of medications also works on that reverse transcriptase enzyme that's responsible for making DNA out of RNA. These medications work slightly different than the nucleoside reverse transcriptase inhibitors. Again, they work on that same enzyme, but instead they stick to a different spot on the enzyme and prevent it from working. And I'll illustrate that also again on the next slide. Here again we see the reverse transcriptase enzyme as the Pac-Man shape in the middle. Again, this enzyme is making DNA from the RNA blueprint. The nucleoside reverse transcriptase inhibitors acted like fake building blocks that would clog up the mouth of the Pac-Man. Instead, here, the non-nucleoside reverse transcriptase inhibitors bind to a separate part of the reverse transcriptase molecule. In the picture below, you can see once the NRTI has bound, it causes a change in the mouth of the Pac-Man, which essentially prevents that reverse transcriptase from continuing to make more DNA from the RNA. Here we have a list of all the NNRTIs that we currently have on the market. Virimune, Sustiva, and Rescriptor are considered first-generation NNRTIs, whereas Entellence and Edirant are considered second-generation NRTIs. The differences between the generation primarily has to do with differences in resistance. The HIV can more easily become resistant to the top 3 than it can the bottom 2. Out of all these medications, Sustiva, Entellence, and Edirant are the ones we most still commonly see in practice, although Sustiva is becoming less popular due to the side effects. Next, I want to talk about the protease inhibitor class of medications. The protease inhibitors work at the very final step of the HIV replication. When new HIV is made, it starts out as a series of long protein chains. Protease is an enzyme that acts like a pair of scissors that cuts up these protein chains into the individual parts of the HIV virus. Once these parts have been cut up, the virus is considered mature because it now has all the pieces it needs to infect a new cell. Protease inhibitors essentially bind to these scissors and prevent them from working. If these protein chains can't be cut up, then they stay clumped together and the HIV virus never matures and is not able to infect a new cell. Here is a picture illustrating this process. You can see on the left, on the surface of the HIV virus, the long protein chains that are all connected together. When protease is working, it acts as scissors that cuts up these pieces into their individual components that then come together to form a mature, working HIV virus. If we break these scissors by using the protease inhibitor medications, then those protein chains are never cut up and they can never come together to form a new mature HIV virus. The virus is then floating around in the blood, but it's not able to infect a new cell and it'll eventually die off. Here we have a list of all the currently available protease inhibitors on the market. Out of all the medications on this list, the two that would be the most important to focus on are Reataz, atazanavir, and Prozista, darunavir. These are the two medications that we most commonly still use in practice. The reason these medications are preferred is because they have fewer side effects, and the HIV has a harder time at becoming resistant to these medications. You can also see that there are several medications on this list that must be boosted. What this means is that we use a second medication to boost the blood levels of the first medication. In the case of Prozista and Reataz, we use either ritonavir or cobicistat as a booster. The ritonavir or the cobicistat increases the blood levels of the Reataz and the Prozista. This makes it so that we can use lower dosages of Reataz and Prozista, and that the patient only has to take the medications once a day. The next class of medications that I want to talk about are the integrase inhibitors. Again, HIV uses the human CD4 cell to make more copies of itself. In order to trick the CD4 cell into making these copies, it turns its RNA into DNA using the reverse transcriptase like we talked about, and then uses integrase to stick this DNA into the human DNA. Once the integrase has done this, the CD4 cell then makes more copies of the HIV DNA. Integrase inhibitors are medications that bind to this integrase enzyme and prevent it from inserting the viral DNA into the human DNA. And again, just for the visual learners, here's another picture that illustrates that process. We have the HIV DNA, and the integrase enzyme simply sticks that HIV DNA right into the middle of the host DNA. Then the CD4 cell, when making copies of its own DNA, also in the process makes copies of the HIV DNA. We currently have 3 integrase inhibitors available on the market: INSTIS, Tivicay, and Vitecta. Integrase inhibitors have very quickly become the first-line medications that we use for the treatment of HIV. The current HIV guidelines, which we'll talk about in the next webinar, have us using 1 integrase inhibitor along with 2 NRTIs to make up most common first-line regimens. The reason integrase inhibitors have become so popular is that they do a very good job at quickly decreasing the HIV virus. In addition, this class of medication has very few side effects and very few drug interactions, so they're very tolerable and they won't interfere with any other type of medications that the patient may be taking. The next class of medications that I want to talk about is the CCR5 inhibitor. Again, as you recall from the overview slide, HIV binds to the CD4 cell by binding to the CD4 receptor. In addition to attaching to the CD4 receptor, it also has to attach to either one of 2 co-receptors, CCR5 or CXCR4. Once it has bound to these 2 receptors, it can then fuse with the surface of the cell and empty all its contents into the cell. The CCR5 inhibitor that we have on the market sticks to the top of the CCR5 receptor and prevents HIV from binding to it. Cellzentry is currently the only CCR5 inhibitor we have on the market. When we want to use Cellzentry to treat a patient, we first have to run a test to see which of the 2 co-receptors HIV binds to. As you can see in this picture, HIV will always bind to the CD4 receptor, but then it will also bind to one of the 2 co-receptors. If HIV uses CCR5 to bind to and enter the cell, then we can use Cellzentry. However, if the patient's strain of HIV uses CXCR4 as the co-receptor to enter the cell, then we can't use Cellzentry, as Cellzentry only blocks CCR5 and not CXCR4. The test that we use to determine which co-receptor the HIV virus uses is called a profile. The final class of medication, and the class that we use the least often, is the fusion inhibitor. When HIV binds to the CD4 cell, and it has bound both to the CD4 receptor and to the co-receptor, it then fuses with the surface of the CD4 cell and empties all its contents into the cell. The fusion inhibitors stop this process, and I'll illustrate this with some pictures on the next couple slides. HIV has a protein called GP41 that is made up of two different parts, HR2 and HR1. This GP41 is essentially a grappling hook that HIV uses to stick to the CD4 cell and reel itself in close to the surface. The HR1 component you can see has the spikes that it gets stuck into the surface of the CD4 cell. Once the HR1 component is stuck into the CD4 cell, the HR2 is kind of the hook or the crank that reels the HIV close down into the CD4 cell. On this slide, you can see the HR2 component in purple has been coiled up along the HR1 component in red. The coiling of these two components together then reels the HIV in close to the CD4 cell, where it can then fuse and empty all its contents. As you can see on this slide, the fusion inhibitors work by essentially clogging up this grappling hook. They bind to the HR1 component and prevent the HR2 component from coiling in on itself, and thus preventing the HIV from reeling itself in close to the CD4 cell, where it then can fuse and empty its contents. Now that we've talked a little bit about the medications and how each type of medication works, the last topic that I want to discuss for this webinar is a little bit about how to build an HIV regimen. When we treat HIV, we use at least 3 different medications from at least 2 different classes. We never use just 1 or 2 medications by themselves. We found that when we use at least 3 medications, that we can keep the virus suppressed and we can prevent it from discovering ways around or developing resistance to any 1 or 2 medications. In addition, when you look at a class of medications where we can use more than 1 medication, the NRTIs is the only time where we can actually use 2 medications from the same class. Finally, when you look at a patient's regimen and you see ritonavir and cabisistat, those don't count towards the total 3 medications, as those are the medications that we often use to boost other medications like the protease inhibitors. Finally, the number of medications in a patient's regimen does not have to match the number of pills. Often we have patients that are taking just 1 pill once a day, but that 1 pill may have 3 or 4 different medications all co-formulated into that 1 pill. Here are a couple of the single tablet regimens that we currently have available on the market. Atripla was the first single tablet regimen that was available. It combined tenofovir and emtricitabine, both of which are NRTIs, with efavirenz, which is an NNRTI. Again, we have 2 NRTIs plus a third medication from a different class. In 2011, we had Complera come on the market, which was very similar to Atripla in that we had 2 NRTIs plus an NNRTI. The difference between these 2 medications was that the efavirenz in the Atripla was substituted for rilpivirine in the Complera. In 2012, we had our first single tablet regimen come on the market that contained an integrase inhibitor. Here we have tenofovir and emtricitabine, both NRTIs, co-formulated with elvitegravir, an integrase inhibitor. In addition, Stribild contained cabisistat, which is the booster that increases the levels of elvitegravir so that the patient only has to take the medication once a day. Our newest single tablet regimen is Triumec, which is also 2 NRTIs co-formulated with an integrase inhibitor. The difference about Triumec is whereas the first single tablet regimens we discussed had tenofovir and emtricitabine, Triumec was the first single tablet regimen to have a different pair of NRTIs, abacavir and lamivudine. Both Stribild and Triumec are considered first-line regimens based on current guidelines for treating HIV. This slide is to indicate the fact that regimens have gotten simpler over time. Back when therapy was new in the mid to late 90s, patients were taking multiple pills multiple times a day. Nowadays, we have 4 full regimens that are available as just single tablets where patients take 1 pill once a day. Reducing the number of pills and reducing the number of times a day a patient has to take pills helps increase adherence, and we have fewer missed doses, and then as a result, the virus has less of a chance to develop resistance to the medications. Thank you all for listening to this presentation over some basic concepts of treating HIV. I know there was a whole lot of information covered in a very brief time over some somewhat difficult concepts. So if you have any questions or concerns over any of the medications or any of the information that was taught in this webinar, please write them down and bring them with you to the live training here in a couple weeks. I'll do a brief review of the information covered in these webinars at that point and can answer any questions that you have over some of the things that may not have been as clear in this webinar.